Okay, well, welcome to week 12 of DH316. Today we're going to be talking about maintenance for the periodontal patient. We're also going to be covering Cambra and SDF fluoride. So if you haven't already had a chance, I would like y'all to, after this lecture, go ahead and go to week 12 in the bbLearn shell, and there are some videos there that I posted and some links to some worksheets that I put together for you. There's an extra credit opportunity under week 12 as well. And I also want you to pull up and look at the ADA risk assessment form. We'll talk about that towards the end, but that's the common form that you'll see in a lot of dental practices. And there's a video to go along with that. So go ahead and look at those videos that I posted and submit the extra credit worksheet if you'd like to. Okay, so chapter 33 covered periodontal maintenance, and periodontal maintenance is also known as supportive periotherapy, and you will also hear it called periodontal recall. Now, highlighted in red are the ADA codes that I talked about previously that you need to start memorizing. So the ADA code for perio maintenance is D4910. And these are the codes that you would find in our clinic on the pink sheet. These are the progress codes that you would enter into Dentrix. And a lot of times in private practice, when you're submitting the final paperwork after you've completed a patient, they ask you to write down your billing code. What treatment did you perform today? So that's why it's important for you to start having these codes memorized. I used to, when I had my own auth in private practice, the cabinet doors were usually covered, so I would tape a little cheat sheet behind my cabinet door that had all of the codes that we used in that office. So that's just a little tip and trick if you want to utilize that when you graduate. If you're bad at memorizing things or you think you might forget, you can always just have a little cheat sheet behind your door. You'll notice down there at the bottom by the dental prophylaxis, this is your adult prophy code, and that's the ADA code D1110. So those two codes you definitely need to have memorized for the final exam. So today we're talking about perio maintenance. It's the continuing care after you complete non-surgical periodontal therapy. So you've completed SRP on a patient. And you keep a periodontal maintenance is after you ideally have done your 4 to 6 week reevaluation appointment, okay? And your patient is not currently in active disease. So that is when we consider our patients ready for periodontal maintenance, when they're not currently exhibiting active decay. And we perform perio maintenance on natural teeth, the natural dentition, as well as implants. And again, we're going to talk about implants later on in the semester. So in the previous slide, I said we perform perio maintenance when our patient isn't exhibiting active decay. I meant active disease. So we're looking for signs of inflammation and bleeding on probing. So once your patient seems stable, that's when we would put them on that periodontal maintenance protocol. So here are the goals for periodontal maintenance. It's to minimize recurrence and progression of perio disease. The ultimate goal is to always reduce tooth loss. That's the whole goal, is to keep the natural dentition as long as possible for the life of the host, and to increase the probability of detecting and treating other oral conditions, and to inhibit recurrence. So we want to bring our patients in and always check how their OHI is, their plaque is accumulating at home. And so it's just our goal is to just bring them in sooner, because 6 months may be too far out, and I know that 6 months is the gold standard for healthy dentition. But just remember, when we're talking about periodontal maintenance, it's the individual host. So it just really depends on how they are keeping up with their home care and how often they are coming in. So this slide is just showing the steps in preparation to determine how your patient or when your patient is ready to be placed on that periodontal maintenance protocol. So ideally you complete SRP, you bring them in for that reevaluation appointment. And then we talked a little bit about last lecture on how you take your assessments, you redo your assessments, your perio charting, you're looking at their bleeding, you're doing your plaque control index. And it all just depends on where that individual patient is. If you bring the patient back in for a reevaluation appointment and there's just 1 to 2 spots that are still bleeding, and we talked about that last week, maybe we just want to retreat that area. If you're happy and you feel that patient is taking your recommendations to heart and you feel like that they are ready to go 3 months without coming back for additional evaluation or treatment, then that's when you're ready for periodontal maintenance. Now, if you are doing your reassessments and you notice that it's a generalized mouthful of bleeding or generalized inflammation still, that patient is not ready for periodontal maintenance. And you really need to have another chat with them and talk about retreating that area, or maybe that might be the time where you might need to refer the patient out to a periodontal office. So during the periodontal maintenance appointment, as always, you would review and update the medical history and take vitals and, just kind of interview your patient to see if anything has changed in their home care or stress or social life, things like that. Just talk to your patients, and you would always disclose and show your patient their plaque levels, because I stress this with every appointment, OHI is critical. Keeping your patients healthy at home is half the battle. At that time, you could identify the individual treatment needs. Do I need to recommend a mouth rinse, an antimicrobial? Does my patient have the need for antibiotics? So that's what it's talking about there when it's talking about identifying treatment needs. Of course, you're going to remove the biofilm and the calculus, because they're going to come back and they're going to have calculus. It builds up fast. I see I see a lot of patients every 2 to 3 months, and they'll come back and they'll have calculus, and you guessed it, where it would be lower anterior mandibulars, always. But the goal of periodontal maintenance, as opposed to just an adult prophy, is that we're going to remove the biofilm supra and subgingival. Okay, so that is something that you need to talk to your patients about when you're talking about periodontal maintenance, is that you're bringing them in, so you're going to go down into those deeper pockets where they can't reach at home. Again, and if your patient is struggling with OHI, this would be the time to maybe show them some pictures or something off the internet. We're going to talk a little bit later on in this lecture about some ways to kind of get your patient to be a little bit more compliant. So how often should you bring your patient back that's on a periodontal maintenance interval? Well, it really just depends. Again, I want to stress that we need to look at our patients as individuals. Okay, not everybody's the same. Some people have more disease, some people take better care of themselves at home, and sometimes there's a systemic issue involved. The gold standard for acceptable periodontal maintenance recall is every 3 months. And the reason why the industry has chosen every 3 months is because bacteria starts to reestablish itself between 9 and 11 weeks. So, if you go over that 3 months, then that gives that host more time to build up bacteria. So just review this slide. I know there's some questions on the exam, the final exam, that talks about the patient and interval time. So the more severe the disease, you want to bring the patients back sooner. The more that they come in and they have a lot of plaque, you want to bring them in sooner. And obviously, if they have a systemic issue, you would want to bring them back in sooner. Trying to get a patient to come in every 2 months is really hard. 3 months, that is what insurance will pay for in the periodontal maintenance code. So again, that's one reason why we use the every 3 months. If you're trying to bring your patient back in every 1 to 2 months, then you have to have the conversation where they may have to come out of pocket with some money to pay for that, and then that is, you know, something that might deter them from coming in. So 3 months is about the gold standard in the industry. So these are some definitions that you definitely need to be aware of. Patient compliance. So when a patient is compliant, that means that they're following your recommended advice. They show up to their appointments and they come in with good oral home care. The non-compliant patient, that's your patient that, you know, no matter what you do, they're still not going to floss. They hate to floss, so they're not going to follow your advice no matter what you do. They no-show to your appointments, and they have lousy oral home care. Statistics show that less than 30% of patients comply with perio maintenance recommendations. You're going to see that in our clinic. You're going to have patients that you get gifted to you from your seniors, and some of them have been in every 3 months. Some of them come in every 6 months. Some of them come in once a year. Our clinic is a little different the way that we run the periodontal maintenance recall, because we are at the mercy of the patients that we have. But just always be aware of the fact that, you know, our job is to try to help them comply. So I'm going to pose the question on, you know, how do we keep our patients in compliance? Well, to answer that question, in our clinic, we like to use those reminder postcards. So that's why those are important to fill out at the end of each appointment when you've completed a patient, because you know, patients like to be reminded. I do know that some private practice offices have a text app set up now because, you know, people don't like to talk on the phone as much as they used to do. So now everybody likes to get texts, and you can do follow-up reminder phone calls. The biggest thing when you're trying to keep your patient in compliance is just limit the amount of info in one setting. If you throw too much information or too many new dental aids out at a patient, they just kind of get overwhelmed. And also, you know, show, tell, do. I see you guys practicing that now. Don't get lazy about that. Just don't forget that some patients don't know how to brush the right way or don't know how to floss the right way. And I always like to say, patients love to hear that they're doing a great job. They love a big old pat on the back just for showing up. The biggest thing you can do in our clinic when you get a patient is just thank them for coming. Thank them for spending, you know, those hours in the chair with you. It really does go a long way. Positive feedback works wonders. I think I've mentioned this before, but to kind of get your patient talking and kind of help them get more involved in their own home care is ask them what they're doing at home and ask them to rate their oral home care routine on a scale of A, B, or C. And then when they tell you what they are, if they don't say an A, obviously, you can ask them, how do we get you to that A? And that kind of opens up that conversation of, you know, I can see that you're doing this at home, but maybe this might work better. So you're really not preaching to them, but just having that conversation and being positive about it. So on the flip side of patient compliance is the question of why don't patients comply? So fear is the #1 factor. Many patients do not like to go to the dentist because it hurts or they've had a really bad experience in the past. Denial that, you know, they don't really believe that their oral condition is in bad shape, or, you know, they've been always under the mind frame of, well, my gums just bleed, that's normal for my family, everybody in my family, their gums bleed, that's normal. So that's sometimes the denial of it. Right in the middle of the screen, you know, the $, it is expensive to go to the dentist. So that's another reason why patients don't comply, especially if they don't have insurance, dental insurance, or maybe their insurance cover doesn't cover it as well as it could. And then also miscommunication. And I think that's a big one, that patients just don't really understand what you're talking about. Maybe it's your fault. Maybe you talked over their head and they don't understand the treatment that they really need. So sometimes miscommunication comes into play. So I always like to try to get my patients, when we're going over the treatment plan, for them to kind of reiterate to me what we talked about during the course of that treatment. So I'm not really just talking at them, that we're having the conversation, so they can kind of tell me what they've heard. And sometimes, even when they come over and the dentist is talking to them, they will interpret something that you may have told them incorrectly to the dentist. So you'll really catch that sometimes, that how that miscommunication comes into play. But these are the reasons why that a lot of patients don't comply. Fear, denial, expense, and miscommunication. Okay, so now we're going to transition into a topic that the book is covering, and it's root caries. And the book states that root caries affects up to nearly 20% of the older adult population. You've seen it in the picture, it's showing you there that it's that discoloration can be caused due to gingival recession, and that it's not linked to a specific bacteria. Root caries is not linked to a specific bacteria, but studies have shown that root caries, if a person has high levels of strep mutans and lactobacillus, that they're prone to root caries. So, you know, not one or the other, but if a patient exhibits both strep mutans and lactobacillus, that they can exhibit root caries. So listed on this slide are the risk factors for root caries. Of course, attachment loss, poor self-care, a diet high in sugar and carbohydrates, lack of dental care, of course, if you have a high history of cavities, people that exhibit a dry mouth or a low salivary flow, and you'll see this in our elderly population a lot due to medications and different systemic disorders such as cancer patients, someone going radiation or chemotherapy. You'll see that their attachment level, they have a little bit more recession going on, and they're just prone to these root caries. So how do we treat it? How do we manage it? Well, they say that prevention is the key to management. So prevention is the key. Preventing attachment loss, slowing down the recession, so talking to them if they're a hard brusher and that's why they have recession, really reevaluating that at every appointment, looking at their occlusal wear. Do we need to help them? Do they need a night guard? Can we help them with the way that their teeth are biting down by offering fluoride treatments when they come in, and specific mouth rinses with fluoride involved. But really, prevention is the key, and as a dental hygienist, that is our main job in life, is the prevention of periodontal disease and the prevention of tooth loss. So this slide talks about some preventative measures that we can recommend or talk to our patients about. Of course, fluoride is the #1 source to help prevent or treat root caries. Fluoride can be found in our mouth rinses, our toothpaste, in gel form, and then in office treatments. Of course, it can be found in some foods, so you can always, this is a really great time to talk to your patient about their diet. Is it high in protein or meat or egg, and is their water fluoridated? Under week 12, you're going to find a video that I have posted from the American Dental Association that's talking about silver diamine fluoride and how it is used to arrest and prevent further decay. It's mostly treated, we mostly see it using it in children, especially children that haven't shed their primary teeth yet. because it does cause a discoloration. So when you watch the video, you'll see what I'm talking about when I talk about discoloration. But silver diamine fluoride is 25% silver, this antimicrobial substance, and then it's 8% ammonia solvent, and it's 5% fluoride, and that's for remineralization. So that's kind of what it's made up of. So there's silver property in it, which is microbial, and it's got ammonia in it, which makes it kind of flowable, and the fluoride treatment itself. So go ahead and go over to week 12 and watch that video if you haven't already. So here's an example of how the silver diamine fluoride discolors the teeth. And you know, this is why it's really, really important that you give a disclaimer before you put this product on anybody's child or any adult, because most adults wouldn't want to be walking around like this, and they would be really upset with you if you put this on their teeth or on their child's teeth without first, you know, explaining the benefits and the risks. So go watch that video. Okay, so we're going to talk now a little bit about Cambra, and on the next slide I'll give you the definition for that, but please, again, refer to week number 12, and I do have a video posted where a dentist is talking about Cambra, and I have also attached the American Dental Association risk assessment form. Look over that. It's a common one you use. I know that we do a risk assessment in clinic. I don't have access to that. I didn't post it. Sorry, I don't have that one here. But basically, we're just talking about, again, prevention in our treatment planning. So go watch those videos. So Cambra is the mnemonic for caries management by risk assessment. You definitely want to know what Cambra stands for, but what do we use it for in practice? Well, we're trying to predict future caries development, and we also use it as a treatment planning tool to take appropriate clinical measures. We can also use this assessment form to talk to our patients or our caregivers about OHI, nutrition, and overall risk for caries in the future. So again, I can't stress that prevention is key. That's what our main job is. And a lot of times when we're speaking about children and some adults, but mainly kids, that some of the caries or the Cambra forms allow us to then kind of wiggle our way into that nutrition conversation. So it's sugar. Sugar is the #1 factor for cavity in a child, for cavities in children and most adults as well. So really, it's a really good tool you have. You know, you fill it out with your patient or with the caregivers, and it kind of just leads you into some more conversation, and it makes the treatment more individualized. So utilizing a caries risk assessment form, let's say that your patient exhibits low risk. So what does that mean? So your patient has no dental caries within the last 3 years, minimal or no visible plaque. They have had sealants placed. They come in regular for routine care, and they've had access to some type of fluoridated environment, be it water or a supplement maybe as a child or as an adult. So using that criteria, how do you modify your treatment? Well, if you kind of refer to the book, it talks about x-rays. So when patients are low risk for decay, and again, this just depends on your individual office. But for instance, if they're low risk, then you might only take x-rays and do a dental exam once a year, okay? And then your fluoride every 6 months at the recare appointment. So, and you know, you would give your basic OHI instruction and always recommend toothpaste and rinse with fluoride. So that's your low risk patient. That's your ideal patient. So here's an example of a high-risk patient that has visible decay at this appointment. They have evidence of radiographic decay. They may come in with those white spot lesions. If you guys look up towards the gingival margin of the teeth, it kind of looks pitted. like chalk colored. Those are what we refer to as white spot lesions. Or they've had any kind of restorations in the last 3 years, which would be evident that they've had active decay possibly. Or if they're coming in with orthodontic appliances, just because that the orthodontic appliances kind of harbor plaque. They harbor plaque, right? And most patients that are in orthodontia are young and they don't like to brush their teeth the right way, just in my experience. So for this particular patient, you might modify your treatment into taking those bite wing exams or taking a bite wing set of x-rays every 6 months to a year instead of waiting the full year. This patient might particularly be on a 3 to 4 month recall. So just things to think about. Now let's go back to those white spot lesions really fast. Those are the areas that you guys kind of struggle with sometimes when you encounter these for the first couple of patients. How much time do I spend deplaquing or trying to remove calculus? You want to be careful with these areas because you can cause further pitting. So I just recommend when you encounter this in clinic the first time, please bring over a faculty member to help you navigate your way through these patients, because we can cause damage and we don't want to do that. And it's very common to see these white spot lesions after orthodontia has been removed. So wherever they had a bracket or a band, sometimes they'll have the white spot lesion there, or anytime that they have had a buildup of plaque and calculus at that gingival margin, they might be prone to having white spot lesions. So you really want to have an instructor point that out to you and kind of help you navigate those waters. So a patient with moderate risk, they obviously have heavy plaque. They admit to frequent snacking in between meals. They have deep pits and fissures without sealants, possibly exposed roots, dry mouth, especially if they admit to you using any kind of drug use. You definitely want to categorize them as moderate risk. So the book states bite wings every 18 to 24 months, but I would do at least every year, recare 4 to 6 months, fluoride at every appointment, and obviously you're going to recommend fluoride-containing products. So just use common sense and use those forms to the best of your ability to modify your treatment. Don't pigeonhole all of your patients. Everybody's different. Okay, so this next lecture was kind of short. Like I mentioned before, luckily the back half of DH316 is all of the things that we're doing in clinic, or you should be doing in clinic, let's be honest. I know we're not in clinic right now, but you'll pick back up in the summer and it will come back to you. It'll be like riding a bike, I promise. So just, review your chapter, utilize any kind of worksheet or study guide that I offer up in the weekly files. So check those for updates. And I'm posting videos. I'm not going to post a video that I don't think isn't important. I'm either posting a video that I like the facts that they give or the way that they relate the information. Some are longer, some are short. So just kind of utilize those. I might throw in a couple of videos that I think are funny if I find any. But anyway, this week, because it is a shorter week, I went ahead and I included a week 12 case study journal. Please submit this via your journal in VB-Learn, just like we were doing in class. I'm going to be checking to see if you guys completed this journal by April 10th, and hopefully everybody participates. I'm not expecting us to come together and host lecture like some of the instructors are, but I am expecting you guys to participate. If I haven't heard from some of you, or if I notice that you guys aren't participating, I might reach out to you and just check in and see what's going on. So here's our week 12 case study journal. You have just completed 4 quads of SRP on your patient who is a smoker and has controlled diabetes. After the 6-week evaluation appointment, you're happy with the results and decide it is time to place her on a 3-month perio maintenance interval. During the conversation, you notice your patient disengaging and playing on her phone. In 1 to 2 paragraphs, explain to the patient the importance of maintaining this 3-month interval and why. Be sure to use language appropriate for the patient. So what I'm asking you to do is, what would you do if this was your patient and you're trying to set up this 3-month appointment because you're so happy that she has responded well to the SRP that you have provided, and now it's your job and the patient's job to move forward into a maintenance phase. So how are you going to talk to this patient about the importance of it? And basically what happens if she doesn't comply with treatment? And just remember to use words to a patient's level. You don't want to use a lot of dental terminology. So I want you to kind of dialogue for me in 1 to 2 paragraphs how you would talk to this patient. So again, thank you for listening. If you have any questions or concerns about week 12, please be sure to reach out to me, and I hope to get back to you soon. I hope everybody's doing well, and I miss you guys.